Welcome to the Prime Health Podcast with your host, Dr. Derek Barron. Dr. Barron interviews doctors, wellness experts, and healthcare leaders who are revolutionizing how we approach health and longevity. The Prime Health Podcast explores breakthrough science, personal and patient stories, and practical insights that are shaping the future of health and wellness. So sit back, listen in, and prepare to transform how you think about your path towards Prime Health with Dr. Barron and his special guest.
Welcome back to the Prime Health Podcast. I'm your host, Dr. Derek Barron. I'm here to bring you cutting-edge insights and practical strategies from leading healthcare experts for your journey in Prime Health in both in life and in business. Now, today we're going to talk about redefining healthcare. I want you to look at it this way. What if in the future of healthcare, it isn't about more technology or more prescriptions, but about rebuilding the human connection between doctor and patient? Now, today's guest, Dr. Zev Myerowitz, of Helios Integrative Health, believes that's where real healing begins. So I know, like you, I'm excited to hear what he has to share with us. But before we jump into this episode, just a quick sponsor from a message from our sponsor, Growth Solutions, where we believe every healthcare professional deserves an exceptional growth partner to match their ambition and reach their potential. Growth Solutions is not an agency or vendor. We are your growth partner. And we take a diagnostic approach to your business. We analyze where time, money, leads, or opportunities may be leaking. So we eliminate stressors in business such as new patient or client acquisitions, marketing and growth strategies, reducing operational chaos with proven systems, frameworks, and SOPs. And yes, we help you with AI and those robots because they're coming for us whether we like it or not. So if you've ever thought this, I'm too busy to grow, I'm too slow to scale, or too overwhelmed to fix it, we can be your solution. Feel free to reach out to me at any point in time. I'd love to have a conversation. But you're here today to learn from our amazing guest. So Dr. Zev, welcome to the Prime Health Podcast, and please tell us a little bit about yourself and what you do.
Hi, I'm glad to be here. Thank you so much for having me. I am both a chiropractor and a distinctly licensed acupuncturist, and I am the Chief Medical Officer of the Helios Integrative Health Group, and I'm also the co-founder of our flagship office, Cape Integrative Health. Cape Integrative Health is one of the largest multi-specialty independent practices in New England, and we are into fixing people. Our model that we've been able to develop really mutually enhances outcomes through multi-specialty care, as opposed to what you might think of as being a typical integrative setting. It's a popular buzzword where you have what's really more likely to be considered a co-op of multiple specialties kind of acting independently. And we've been able to develop a significant amount of intellectual property in being able to use them in tandem to mutually enhance outcomes, and specifically in regards to musculoskeletal care.
Okay. All right. That's a mouthful. I appreciate you sharing that. We're going to dive deep into what you have, because as we talked before, you guys are really making big changes in healthcare on the East Coast to start, and the goal is to maybe move across the country, which, I'm looking forward to seeing what that happens. But I want to kind of back up a little bit. Was there a moment in life, a circumstance, or anything that made you choose a career in healthcare?
Yeah, so I'm a third generation chiropractor. My dad's a chiropractor. My grandfather's a chiropractor. I have two brothers that are also chiropractors. And, from a really young age, it's kind of a fish in water situation where I grew up in a scenario where if you had a headache or your back hurt or you had a hard time turning your neck from side to side, I would either see my dad or my grandfather. They would identify the issue that was happening, and I would either be adjusted or there'd be some level of muscle work that had to be done, and my headache would go away. And so, I grew up with a life experience where if you had a musculoskeletal problem, you would readily and easily find the person that could correct that, and you would be able to just get back to it. And it wasn't until later in life, particularly with high school, I was a very active teen. I played 12 seasons, 3 different sports, all through high school, and continue to compete today. But it wasn't until later in my life I started to understand that really wasn't everyone else's reality. I would have teammates that would have very similar injuries, but then would go through a more typical medical model, and they would be sidelined for 4 to 6 weeks to let something, heal, and then it might not, and they needed to try physical therapy or a different specialty. And the imprecision of the healthcare model would cause people to lose opportunities as part of the management. And, it only takes 1 or 2 seasons of these kinds of things before you just kind of fall so far behind that you wash out from that opportunity. And so, I started to really gain perspective that the population at large didn't have access to the kinds of services that was just my general life experience. And so, going through school, I was really insistent in a multi-specialty model. I did an internship at the Beverly Hills Comprehensive Medical Group, which was a combination of urgent care, physical therapy, chiropractic, massage, acupuncture, and I got, I could see how those synergized to provide a superior outcome. And it gave me the concept of what my wife Amber and I wanted to launch once we moved back to Southern Maine. And our practice has quickly grown. Way back in 2012, it was her and I and a bunch of loans. And now we have 15 full-time equivalents, well over 20 employees at our central location. We now are closing on our 10th office. We have well over 100 employees, and it's like the Seinfeld yada yada yada. But there was a lot that happened in between that time. Yeah.
So what are Thanksgivings like? Is there this family football gathering that you guys all compete against each other when it comes? It sounds like a competitive nature in the family.
I mean, we're a pretty competitive family, but it's waned a little bit in the physicality. I think at this point it's mostly card games and that kind of work that we get into. Although for my 40th birthday, I took a trip with my closest friends and my brothers, and it was barstool sports for 24 hours a day, whether it was volleyball or golf or darts. And so we're a pretty competitive group, but we have fun with it.
Yeah, you are competitive. You've explained that. We'll get to that a little bit later as well. So I want to dive into the meat of what you're really doing within your business, which I think is great. So there are a lot of people, even what you just explained of when you were in school, that they go through the common aspects of healthcare. They see multiple providers, they get a bunch of different scans, they get a bunch of different tests, they come back and they're all being told that there's nothing wrong with them and there's nothing that they can do to help. Why do you feel that still exists today?
Well, it comes down into 2 major categories. We have a training and a medical model that is hyper-specialized. And so the more specialized that you become, the more reductionist you come in your perspective, where you're really good at managing the nuance that's relative to your tiny little sandbox, but the inter-exchange or the inner effect of how regions affect each other from more of a functional perspective, we really tend to lose the ability to see how that relationship affects adjacent tissues, especially when it comes down to very, very fine anatomical detail. And so, if you're a foot specialist and someone's coming in with a foot problem and you're not able to quickly identify that that's compensatory from a knee or a hip issue, that person's probably not going to have the tools to manage something, or they're going to treat the symptomology as opposed to the primary causation. I have 4 children. If one kid's crying, I know there's another kid somewhere else looking guilty and not making any noise. And musculoskeletal care is very much like that. Short of acute trauma, car accidents, things along those lines, you generally will have a problem that's hypercompensating or having to make up the slack for either too much mobility or lack of mobility somewhere else. And if you don't address both of those problems simultaneously, you're typically not going to get the outcomes that you're looking for. And so in the medical model, because we have this hyper-specialization, a lot of the times we miss this holistic or regional interdependence approach where you're actually able to see how the body moves together and really identify where the causation is. The second major reason why we miss these issues is that we have to have justification for why, anytime that we have a problem, we have to have a test in an insurance-driven model to prove medical necessity of why we're making an intervention to solve the issue. And that makes sense. There needs to be accountability for why we're doing what we're doing, from a documentation and logistics perspective. But there's a massive subset of functional movement cases that are limited or driven by what I would call like neuropathic or neurodynamic pain. But the injury to the nervous structure itself isn't bad enough to be picked up by a nerve conductance velocity test, or it's not specific enough to be picked up by an NCV or an EMG. And so we have this whole subset of very painful conditions where people can't move correctly, or they have peripheral nerve type discomfort that is limiting them in a certain function, and we don't have a test that shows it's bad enough to justify an intervention like a carpal tunnel release or a ulnar nerve transposition, something like that.
Mm-hmm.
And so, the orthopedic surgeon can't do anything. The physical therapist can't do anything because they don't have the manual skills to necessarily elicit exactly where this problem's coming from. And that's not a dig on physical therapists. We have amazing, talented ones in the Helios group. I'm simply saying if you don't have the lens in being able to recognize this pathology with very skilled manual hands, we don't yet have the technology to confirm these problems when they occur in the musculoskeletal space. And so we have a massive subset of patients that are gaslit by the system because they don't have a test with enough resolution to prove causality, and therefore we can't justify an intervention.
Yeah, too often it's microscopic and I guess magnifying glass practice, meaning they come in and they point, it's my elbow, and all they focus on is the elbow and 2 inches above and 2 inches below and have no care if it's anywhere up and down the chain. And it's robbing that patient of expediting their care and their improvement in life, which is really unfortunate.
One of the biggest hot topics that when we do some of our social media reach outs, I talk about complex regional pain syndrome. Okay. That's a very good example of what I would refer to as like a generalized dysautonomia. There's almost always a trauma to a structure, and then the adjacent soft tissue response causes neuropathic pain, typically down a peripheral nerve distribution. But often these cases aren't bad enough to be picked up by an NCV. You see anything from atrophy changes to vascular changes, and it's exceedingly painful. And most of these have a very mechanical solution. Sometimes they need to be co-managed with some of our regenerative medicine specialties or even some injections to help make it comfortable prior to a manual intervention. But I mean, complex regional pain syndrome, people are kind of told to go home and deal with it, and we don't have a solution. And these are people that are in so much pain. I mean, there's suicide idealization because it's just so difficult. These people can't escape this reality. And this is a category of injuries that falls under this same type of problem that we in healthcare don't yet have the resolution to be able to identify. Some specialties are actively working on it, but right now, outside of skilled manual intervention and being able to identify where the pathology is coming from, there really isn't a solution for these patients.
Yeah. Now, I don't know this for sure, but I would assume you leaving school didn't quite have this knowledge. I know that you're big in ART. Is that something that's helped you? Like you came from a great family background of it. You sound intelligent while you were in school. I'm sure you were excelling, but what helped you get a bigger grasp on this ability to be a better clinician?
I was hyper focused on neuropathic pain, even as a student, because of the dual chiropractic acupuncture approach, and specifically how acupuncture can improve nerve healing or nerve regeneration far above baseline. A lot of the practice work I was doing right from day one was focused on denervation patterns. So, severe disc herniations with foot drop or motor weakness, and how do we get that back? And so combining acupuncture protocols where we're helping to stimulate the nerve, often we would do needle acupuncture within either the ear or the motory sensory cortex of the brain to help improve neuroplasticity so that the person can grow and rewire those patterns faster. And so there's always been an interest in this multimodal approach, particularly with nerve pain or nerve pathology. And then I quickly really fell in love. So I'm tool agnostic. I'm not, there isn't a particular tool that I think is the only tool. There's no such thing as one tool for everybody. But that being said, I'm a big fan of active release techniques. I'm one of their lead instructors. I helped to develop their curricula. And I became involved with them around the same time that we developed their nerve course, which really applied clinical neurodynamics to a far higher level of resolution. And it was the very first tool that we developed that gave providers the ability to be able to didactically sequential treatment plans to release these very complicated nerve problems. And so it's for these particular subsets of pain patterns, it's not the only tool, but it is one of the best tools when you can apply it.
Okay. Love it. So there's watching some of your videos that you've done, you've spoken about nociplastic pain, and it's entering this vernacular of everyone that's out there. It's a big word. Please explain it for those that don't quite understand it, but what does it actually mean, and what does it mean to you and how you treat your patients?
Yeah, so the term nociplastic pain is, so there's lots of, let's give some open up a thesaurus for a second so we can explain some of the differences. So nociplastic pain is the description of chronically painful stimuli because there's been a sensitization of the person's nervous system. Okay, there's a lot of research that shows that in patterns of chronic pain, some of the fibers within the spinal cord actually get transitioned to different kinds of fibers that are more sensitive. And I'm trying to keep it very simple. But if you're in pain long enough, the idea is that your brain can rewire so that you chronically are in pain. And so what a lot of the times these patients that are like chronic regional pain syndrome, a lot of the times providers will overuse that term to describe a mechanically reproducible pain and blame the patient's nervous system for a problem that actually has a mechanical solution. Okay. So neuropathic pain means that the nerve itself is a pain generator, which we know can occur. And so there's other terms that are very similar, but the term nociplastic is often used as a catch-all as a substitute for the inability to diagnose or make an intervention to correct the issue.
Okay. So if we jump back 5, 10, 15, 20 years, the term, where people have fibromyalgia if we look at it today, it's a garbage can term. People will be offended when I say that, but it's because they didn't know what else to do. It sounds like that nociplastic may be thrown in there right now because they're not sure. They don't have the tools, the manual therapy, the manual grasp of what you're doing to realize it's not, again, just the elbow. It's around that region above and below.
Yeah. And I agree. It's fibromyalgia was a diagnosis of exclusion, meaning that once you've excluded out any other potential diagnosis that you could figure out, you would slap them with that label because you don't know what it is.
Yeah.
Things hurt and you don't know what it is. So the idea, we now know, fibromyalgia can be anything from, generalized systemic inflammation to for example, a chronic untreated Lyme disease to, gut biome problems where your body's having food reactions within your bloodstream. Like it is a catch-all, but there's a lot of reasons why it can happen. And so nociplastic pain, there are examples where it's a little bit, not in the mental health, but like CBT, cognitive behavioral therapy, can be very useful for true nociplastic pain. But that term absolutely is inappropriately applied to people that have mechanically reproducible pain that, hurts when I do this, doesn't hurt when I do this, feels better when I go a certain way. In the hands of a skilled manual provider can actually reproduce the exact problem and identify the tissue that's involved. That's if you can make a change and it's getting better, that's by definition, a mechanical interface issue and something that isn't in the patient's head, if you will.
Yeah. Yeah. Our bodies don't always have, when you walk into an office, the check engine light and then the next step of what to do. You've got to be good at the analysis of what you're doing on it. So when you have patients that come in, Dr. Zev, what's the difference of those that are being told, we can't find it to it's in your head? How often do you see that come into the practice?
Only on days that end in Y. It is, I hyper-specialize on this. We have a tremendous team of chiropractors. We have urgent care. We have physical therapists. We have acupuncturists. And so I restrict a lot of my new patients to this specific subcategory because by the time they make it to somebody like me, they've done most standard models of care. They've tried physical therapy. They've tried injections. They might have even already had surgery and their problems weren't solved. And so it is so immensely commonplace that we have a steady stream just from our local orthopedic group on people that have these types of problems. And the way they can rationalize it is you have what appears to be a myofascial type pain or neuropathic pain, and with a negative nerve conductance velocity test, they can't do anything. They have no justification to do anything. And therefore that usually gets sent to us, especially if it's failing physical therapy within their organization.
Yeah. I love the fact that you have the relationships with the orthopedics. It's important. The good part is in the days in the past when they couldn't come up with something, it would be physical therapy, or it would be like you're saying, it's just in your head because we can't fix it. That doesn't mean someone else can't. And then it's worse. And it's my wife's a physical therapist. It's not that they aren't good, but if they can't fix it, there are chiros that don't fix it either. That's why you're a specialist. But when there's nothing wrong with, hey, let's try this next step. And it sounds like you're showing that you are a great next step option for people in your community.
Absolutely. And it's a two-way street. I mean, if we have mechanically reproducible neuropathic pain and it's non-responsive to treatment, the next appropriate step is to order an NCV, because if the nerve is damaged to the point that it can't recover from manual intervention alone, then we really do need to consider some kind of release or decompression to help get the tissue to solve. And then maybe there's a secondary process that we want to still be involved in, but it kind of goes back to our larger mission statement. So at Helios, the provider is the product, and we're here to solve people's problems. And so whether that is us or just managing the case to where it needs to go, if as long as you have a clear plan in place and the patient is progressing forward, and if they're not progressing forward, you do need to get them to where they have to go to solve their problem. And as long as you can do that, you've already established that you're a resource in your community to help these people in need.
When you say the provider is the product, that probably means that you are actually taking the patient feels seen, or they feel heard when they come to your office, because they're pushed away at other places if there's no option to go. So they finally feel it with your practice.
Yeah. What exactly, what I mean by that is that the providers within the Helios group, we invest a tremendous amount of time in cross-training them between our different specialties, so that they know not just what is kind of within their lane, if you will, but what also is mutually enhanced by other specialties, and where the lines are when we need to then co-manage or refer out to help get the outcome that we want. And so, take a good example. We have somebody with a notable disc injury. We have multiple layers of mechanical intervention to see if we can get a directional preference. If the pain is so exquisite, we need some pain control, we can pull in our urgent care from acute management. There's specific medications that are quite effective in here, so that the patient can at least tolerate that really severe initial phase. But there are also very clear lines in which, if we're not seeing progress, or if there's any of the red flags, we take a full stop and either immediately go to MRI and simultaneously pull in pain management, or pull in our surgical colleagues to help prep for a decompression. And so this patient is going to get what they need to get relief one way or another. 90% of the time it can be managed conservatively, but 10% of the time it can't be. And you need to be able to effectively manage, or at least triage, this patient to where they need to go, so that the next time something happens, they know you are able to quickly identify and solve their problem.
Yeah. And the beauty of your practice, me not knowing it, but what you've been explaining to me, is that they're always in-house. I'm sure at times that they will leave, but an option is, if I'm not getting the answer, I can ask and I can share, and another provider comes in, versus they go to the orthopedic surgeon, they refer them out to physical therapy, then they go back to the orthopedic surgeon, then they're referring them to another person. And that's weeks and months and waiting for a script and waiting for options, versus it's all done within your office, the four walls of your office, which is so beneficial for the patient.
Yeah. I mean, one of the biggest crimes I see in the healthcare space is the complete disregard for the patient's time. Yeah. And, some of that is related to the constraints of the healthcare system, in terms of provider shortages, but we have there is a tremendous amount of opportunity and availability for skilled providers to have access to these populations. And when you design efficient systems, you quickly manage populations, therefore allowing you to manage more people more quickly, more effectively. Mm-hmm. And that's really where we, as a country, really need to be moving towards, is cost-effective, fast patient management. In my local area, if we have a patient that we pick up with an arrhythmia and we want to send them to cardiology, I mean, we're looking at anywhere between 3 and 6 months to be seen. Most nerve conductance tests, depending on the group you're sending to, still currently are 2 to 4 months out. And, shortages like that really make it difficult for you to be able to, like, if that's your system and that's the lane you have to work in all the time, I don't understand how you can actually manage anyone cost effectively. And, at least within our model, we understand that it may be an issue, and we can order the test, because by the time that test comes around, we know if you're clearly getting better or not from our interventions, and that test will confirm the pathology if it's not getting better. And now you've already saved 3 or 4 months of time, so we can get you where you need to go.
Yeah. I watched a couple of videos that you had. You had some stuff on Instagram and TikTok that talked about the quiet miracle of being seen, which I think is what you're explaining right now.
Yeah. So the quiet miracle of being seen, that when you are a patient and you've had this mechanical problem that no one has been able to replicate. I mean, you probably have seen 10 or 12 different people, and no one's actually put their hands on you to identify what that is. And so everything's diagnostic, everything's dehumanized.
Yeah.
And when you finally meet that provider that not just puts their hand on the exact spot and confirms with you that what you're feeling is the issue, and can either make a subtle change or traction it or alter it in a way that affects the pain, you as the patient know that that provider actually understands what you're experiencing when everyone else hasn't. They finally see who you are and what you're experiencing in your life at this time. They see you. And when that happens, the patient finally feels like they're being understood, and they're finally on the path to where they need to go.
Yeah, it's probably a mental and emotional release that I'm finally at the right place where there is hope still for me.
Yep. Yeah. It happens on a daily basis with us, but it's really hard to see, how frequently people go months, if not years, before they actually find the right place. And, for every patient that has worked so hard to find an answer, I'm sure there's several of them that just give up and assume that this is how it's going to be. And it doesn't have to be like that.
Yeah. Yeah. Well, it sounds like a big problem across the country. It's a problem that you're tackling in your community. So if there's somebody that's watching this, or if they're listening to this and they're local to you, or if they're somewhere else, what would you say in that situation there right now? What do you want them to walk away from here thinking about how, if they're not in Maine, how can they talk to a provider to finally get to be seen and be heard?
There's good avenues that people can start to roll into. So first of all, Helios, we have 10 different locations throughout New England. We're all the way down to Connecticut, and we're going to be in New York shortly. Okay. And so our network of practices are with skilled providers that can recognize and manage these problems. But if you're in an area that doesn't have access to that, if you have not worked with an active release techniques trained provider, and you've already failed physical therapy or traditional chiropractic or acupuncture or something along those lines, I would strongly recommend you see a provider that is as trained in that specialty as possible, because they often will have some of the tools to be able to at least assess what the issue is and have a plan. But this is a real problem. I believe that we are doing something very special, and we have patients that do fly to our offices as far away from Texas. We have patients that drive from 5 or 6 hours away, and the opportunity is enormous in patients being able to finally gain access to what they need.
That's good. Well, they're fortunate on the East Coast. You'll slowly grow across to the West Coast, I'm sure.
Our biz dev pipeline is very strong.
Okay, good. When you're talking about ART, active release technique, you deal a lot with fascia. Fascia is something that people hear about often. Would you mind kind of explaining to layman's term what fascia is and how that can hurt them, and what an ART provider or someone of that nature can help them to get relief? Yeah,
so fascia is kind of the new frontier on managing musculoskeletal conditions. Neurodynamics still hasn't made its way through most of the school system. So in about 10 to 15 years, I think they'll start catching on that. But fascia is really like what's happening in the bleeding edge of research over the last few years. There's a couple researchers in particular that are making major inroads into our understanding of it. But fascia, if we think of it as, it's the connective tissue that wraps around the everything. Meaning that individual muscles have fascia that ensheath them. Nerves have fascia that ensheath them. Compartments of your leg are separated by fascia. And then the outer layers of your limbs or your trunk or your core are all layers of fascia. And the majority of our mechanoreceptors, the things that measure pressure, vibration, like touch, hot, cold, pain, they primarily, lots of them exist within our fascia. So our sense of who we are and where we exist is based on receptors that are within our fascia. And so it is the connective tissue that wraps around everything, but it is also an anchor point for our muscles to pull and load from. We traditionally are taught that muscles attach to bones and move bones, like simple levers. And that is true, but that's not complete. Okay. And so, the lower leg alone, the majority of the large muscles in the front of the leg primarily attach to fascia. And if you think of it as like sausage casing, just for a metaphor, they use that rigidity as another place to leverage force from. So depending on where you are in the body, like take the Achilles tendon, the majority of the load doesn't actually go through the Achilles tendon. It goes through the posterior crural fascia. And so it is a major tension loading system within our body that slowly develops throughout our lifetime based on the stressors that we place upon it. And so when you understand fascia as being not just a source of stability, but also a place of potential loss of mobility, then it starts to provide yet another place that you can assess the body to see where functional movement problems can be limited by. And and it's incredible how interconnected it is. We were in a functional cadaver lab where bodies that were unembalmed were prosected specifically for us to study this. And you could load tension down the back of somebody's leg by moving their opposite arm. Wow. It's incredible how much those kinds of things can affect the body when you sequence the movement out to load that kinetic chain. There's a very good book called Fascial Trains that describes the major fascial systems and where the load runs. And if anyone's interested in that, that's a great priming book for people to look at. But very quickly, we're going to see a lot of the professional athlete work really focuses on loading these things and developing strong movement patterns. And it's starting to trickle down through what I would consider more standard medical educational institutions. And it will probably start to become more foundational understanding in about 20 years.
Okay. Well, let's hope it's a little sooner than 20 for everyone's sake. Yeah. So from a personal level and a professional level, I know you're a high level athlete in what you do. How has that changed how you approach your practice?
So I'm a competitive triathlete and a road cyclist, and it's a very interesting sport. You have to like type 2 fun to be proficient in both of these, because discomfort is usually you getting the most out of yourself. But they're very interesting in that you can take a very scientific approach to improving performance. You can analytically study what you would call your power curve and where your strengths and weaknesses are, and address those individual issues and make changes. And even, I'm in my early 40s, I'm still getting faster. I'm still seeing performance, but I'm addressing training stimulus towards deep strength endurance versus heat tolerance versus neuromuscular recruitment and all these different areas to help improve performance within the body. And so, it carries over very strongly when you're taking care of people in recognizing where their individual weaknesses are and where the opportunities for improvement can occur. And if people are coming in with multi-level problems, 6, 7, 8 things on their problem list, we can address the most systemically important issues to start working on, or just the ones we can make changes in immediately if others are being currently limited, and then sequentially start making improvement and working on weaknesses and moving them forward. And so the two are very similar. I work on trying to improve other people's areas of weaknesses during the day, and then between 4 and 7 a.m. I'm working on my own.
A busy man, that's for sure, with the growth in yourself and in your practice. So I recommend, I don't know if I can recommend the lifestyle you lead, but it sure looks like it's successful and it works for you. Everybody's unique in what they do.
It's a busy day.
Yeah, it sure sounds like it, with kids especially, to put on top of it. So I'd love for you to share maybe a success story of somebody that's come in that wasn't being seen, wasn't necessarily being heard, or is getting shuffled away in the system, and how you brought them back.
Yeah, so a case that I just finished up with right now, we had a a tradesperson, a very hardworking blue collar individual, repetitive use injury. I can't say the specific mechanism based on my location. It's a little too close to HIPAA, but repetitive use injury, notable loss of sensation in the first 3 digits, quickly diagnosed as a carpal tunnel syndrome, received a decompression of the median nerve at the carpal tunnel, had improved NCV findings following it. There were no notable NCV findings anywhere else in the body, and the patient was still experiencing very notable hand pain, but also notable pain in the subclavicular fascial region that was difficult to reproduce orthopedically outside of N range, has every other test under the sun, MRIs, CT scans, X-rays, ultrasounds. Nothing was torn, nothing was a problem. The NCV test didn't show pathology. And so this patient was diagnosed like with blanket myofascial pain syndrome, and was kind of, the end of the road kind of occurred there. The surgeon I knew, and we had consulted on it, and was sent my way. And we were able to very quickly reproduce the patient's problem as being what is a precursor to the median nerve. It's called the median cord. It's not the exact same structure, but it's kind of like an upward stream of a nerve that contributes a lot to the median nerve. And this particular structure was really entrapped at something called the corticopectoral tunnel, but it's the space underneath the pec minor that the entire brachial plexus transfers through, where all the nerves intertwine and become different structures as they're moving from your neck all the way down to your upper extremity. And within a very short period of time, we were able to dive in and not just restore the patient's range of motion, but also restore sensation and grip strength. And sometimes it's what people don't understand is that nerve pain, neuropathic pain is cumulative, meaning that you could, let's say you needed a score of 100 before your body became aware of pathology in your hand. You can have a major issue in your carpal tunnel, and that nerve irritation over time is going to cause compensation upstream. Your fascia is going to generally try to stabilize that nerve up the actual median nerve pathway. And if it's left to occur long enough, you can develop secondary, if not tertiary, entrapments that can limit the outcome from a single intervention. And so in this patient's individual case, we were able to identify exactly where that issue was coming from, make a change, and now this patient's actually on their way to healing. Where the existing system would have said, it might just take some time, go home and live with it. Here's some pain meds. We don't have anything else we can do for you. That's I would say that's a daily occurrence. That's just something I saw earlier today as a follow-up. But it seems like fish in water for us because that's just what we do all day. But I just want to stress that's the person who's not generally getting what they need in the healthcare system at large. I mean, I'm sure there's thousands of these people every day within the healthcare system that are feeling gaslit because providers don't have a test that can prove where the problem is, and therefore the system tells them to put the onus on the patient.
Yeah. And the truth is, you couldn't go through that diagnostic approach with that patient in under 7 minutes, which is what our healthcare system is giving patients and providers right now. There's just no way you can. And therefore, there are many people sitting at home dealing with that problem. Had they seen yourself or a provider like yourself and had a secondary outcome, they'd be in a better place. Now they're going to potentially be in that cyclical pattern of being dependent upon drugs and thinking to themselves, there is no way out of this. And it's just it's a stairway down that you don't want to get on.
Right. Yep. Absolutely.
Yeah.
Yeah.
Who would you say are some ideal patients for you and or in your practice?
Anybody who has a functional problem that is mechanically reproducible, that has already gone through one form of healthcare, like if you're having mechanical pain, try to find the resource within your community, because the simple things are going to respond to the standard healthcare space that work well, whether that's a physical therapist or a chiropractor or an acupuncturist. And, as with all things, it's not the specialty, it's very much the provider. So if you saw one provider, that doesn't mean that specialty may not work for you. It might mean that individual provider doesn't have that skill. And so if you're having, severe pain that has not been yet diagnosed, that people can't quite identify, that's mechanically reproducible, then that would be the patient that might consider looking at a Helios provider with one of our organizations. And we're happy to treat standard mechanical low back pain, chronic tension headaches, anything along those lines. Like that's what we do all day. Tension headaches in particular, a lot of people are on excessive management for those when there are almost always a mechanical solution to give greater carryover with it. But, if you're not within our area, use your community first. And then if this sounds like your story, then you're certainly welcome to reach out and consider seeing one of our practices.
Perfect. So what do you see as the vision of Helios in the next 3 to 5 years?
So I was the I'm the immediate past president for the Maine Chiropractic Association. I still chair the legislative committee, and I have worked for well over a decade in trying to advance healthcare in this particular way in the public space. And, it very much feels like a no man's land on a World War I front, meaning that like the professions are all fighting about scope and scope creep and who can do what. And you might win a little here, you might lose a little there, but the end result isn't a whole lot different. And if you're really going to make a change in the healthcare space, you have to do it at scale in the marketplace by providing superior outcomes and a superior patient experience. And so that's what we're doing. Practices that are interested in joining us or reaching out, we're accelerating our growth pretty quickly because the more, especially the chiropractors, the more experienced they are, the more they start to realize that there's something that they're missing and they can't quite identify what that is. And those providers, once you see this particular kind of training and the mechanical reproduction of what the problem is and actually start to feel and understand it, you can't unsee it. You just can't go back. It completely changes your perspective. And so I see within 3 to 5 years us very, gaining speed. We're doing this the right way. We're taking our time, but gaining speed and rolling this out and changing healthcare at scale.
Love it. Glad I'm happy to hear it. And I know that the success will come your way. So as people are listening to this, if they're seeing this, if they want to learn more about you, or how would you suggest they get in touch with you and or Helios?
So we're at heliosintegrative.com. My individual office is capeintegrativehealth.com. I have platforms both in Instagram, TikTok, LinkedIn. I am constantly putting out content to try to raise awareness on the conditions that we address and approach. And those are the major platforms in which you can hear and learn about us.
Okay, perfect. 2 last questions for you, Dr. Zev. If you could give one piece of advice that could affect everybody that's listening or watching in a positive way towards their health, what would that advice be?
Well, I'm going to give 2. So the first one is you got to move every day because chronic disease is the number one avoidable killer in the United States. And if you move your body for 30 minutes a day, 3 days a week, you reduce the chances of suffering from one of those conditions by over 50%. We got to move. Yeah. Okay. Doesn't matter. And it's preferable if it's something that you really enjoy, and if it's not something that you enjoy, it's better if you do something that is at least social so that you're getting that element too. I don't mind if that's hiking with friends there was a couple seasons I did inner tube water polo and it was really fun.
Okay.
So getting people to move, that's the first thing that we have to do. We got to move more. Okay. And then the second thing I would say is you as a healthcare consumer you are the consumer. Okay. If you are unable to find the solution in your marketplace to solve the problem that you have, there is a very good chance that it exists elsewhere and that you as the consumer have the right to look to other places. So my other advice is don't give up because there are people out there that have the tools to help you with your problem. The more rural you are, the harder it is to find. But I encourage those people to keep looking because we exist.
Yeah, love it. Well, and you're going to be found more prevalent out there as you continue to grow with Helios. So the last question for you, Dr. Zev, is you've been a great and amazing guest here on the Prime Health Podcast. What is your personal definition of Prime Health?
My personal definition of Prime Health is the consummation of peak physical, mental, spiritual wellness. Okay. You're in the hierarchy of needs, self-actualization is a big one where you are working, you have found your life's purpose and you are working towards driving something that defines who you are and where you are in this world that we live in. So both from a professional and spiritual approach, that has major implications. Family is a huge component of the spiritual approach. but you also need to take care of your physical body. You need to move your physical body. You need to do things that, that either scare you every day, or are working on your own individual weaknesses to be the best version of yourself. Mm-hmm. And, one of the biggest quotes that I love is, Eleanor Roosevelt's "Do something that scares you every day." Yeah. And it serves two folds. One, we're growing constantly as people, but also if you're constantly doing the same thing, our brains pattern so that when we're in habits, we kind of slowly turn off. And so this whole idea that as we get older, time really flies by is directly correlated with reducing novel stimulus. Okay. So as we age and as we are moving forward, do something that makes you uncomfortable. Do something new. Do something that you might not otherwise go, because that's what's going to fill the days, the months, the years, and make you remember a full life.
Yeah. Awesome share on that, Dr. Zev. I really do appreciate it. Take it to heart and to mind for myself, even about the instructions that you've given us laid out in those. And I really want to say thank you very much for sharing, your expertise and your experience. It's great to see you come from an amazing family backed with chiropractic. You've taken that into backing it with unbelievable knowledge and care. You've built out a practice that not only grows for you and your wife when you started with the big loans, and I hope those are much smaller loans nowadays.
We're doing better.
Yeah, that's good to hear. That's good to hear. But I think there's a lot that can be taken from a provider perspective from this podcast and also a patient perspective from this podcast. There's actionable items that are there. So I always tell people that are watching or listening, if you think one person can benefit from this, please do share it. It's important that the message that Dr. Zev is sharing from Helios and from himself gets out there. There's more people that we know that are saying, hey, I went to 3 different docs. I got no results. I'm done. I've had enough. And the truth is, as he just said, don't give up. You're never done with care until you feel better. And the options are there as long as you continue to go after them. I always ask for people to subscribe. We would like to share more of this as we get great providers and individuals like Dr. Zev as well. So until next time, remember that true wellness is a journey we are all on together. Whether you're taking charge of your own health or guiding others in theirs, please make sure every step forward matters. And please do stay committed to your Prime Health journey. Again, Dr. Zev, thank you very much for being a great guest here on the Prime Health Podcast.
Thank you so much for having me.